we'll start with the grand rounds for today. And we have a very important topic, which is the management of acute variceal bleed. We've got presentations from our side, from our ancillary departments who help us in managing these patients, as these patients are very sick and need teamwork to manage these patients and help improve their outcomes. So this is our plan, and may I now invite Professor Pramod Gar, who's the head of department, to take through us.
Thank you, Shalimar, and I'd like to say that we're extremely happy to see you here. I can't take any credit for this. This is Shalimar. He is very popular areas. But also, the department has to communicate something, because the topic we are going to discuss is extremely important, regardless of the research. So, if you are in medicine, surgery, or you will see patient to check. Either a new patient, you can't escape without seeing a patient check. And checking over the last so many decades has remained a major problem in gastroenterology. Fortunately, in the last about 20 to 30 years, we have made significant successful interventions, both in pharmacotherapy, endoscopic therapy, and radiological intervention, besides surgery, that our outcomes are much reduced. Variceal bleeding is something in India and in many parts of the world is always for upper GI. In the past, we used to believe it is not but today, at least in India and many parts of the world. One of the reasons for that would be that the disease in general perhaps has gone down in its incidence because of availability of very effective anti-acid medications such as inhibitors. Also, the treatment for headache, which was dominant or used to be dominant, now what we see is NSA inducer and NSA inducer. That's the reason why there is so much. Another reason is that there is a very mortality and someone has underlying liver disease, very high. I'm very happy that over the past about 40 years, my teachers have done original cellular work in the field of and variceal bleeding, and given us new knowledge with regard to and clinical impact of variceal bleeding. We show some of the old and the new data that we have. So for the residents here now, here, 50% of patients with cirrhosis are during their life. Okay? Then it correlates with the severity of disease, like the toxicity of more severe hypertension, large majority of patients with and the incidence of for a broad population is 1/3 of patients with cirrhosis disease, and 1/4 and in fact about 1/3 will die of it. So that is statistics with regard to it. The other cause of focal hypertension being there are two categories. One is non-cirrhotic focal fibrosis, which fortunately has gone down. We hardly see patients the group that we see still is a focal law, and this is because of many reasons. Where we definitely manage even today, it makes a surgical chunk of in regard to surgery, they have done excellent work in that regard and presented in their CTR the long-term outcome of those situations. For acute bleeding, we manage like we showed, but so today our focus will be on cirrhosis and variceal bleeding, and this is just a glimpse of the and we have developed our own algorithm in managing these patients. And I will tell you, in the GI practice, there are two major emergencies where endoscopic therapy is effective. One is GI, this is emergency that you are but we did in the fact that our medicines can manage any severe GI bleed in any situation because we get 8 to 10 patients and everything we get so with that, over to you.
Okay, thank you, sir. So this is the overview of the next 40 minutes or so, what you're going to hear from us regarding the acute variceal bleed management. We every day are managing at least 5 to 10 patients with upper GI bleed, and these all patients come to the emergency department, and we are thankful to the emergency department for helping us in managing these patients. And what sir said, we are always wanting more and more beds, which is always an issue, but then with their help, we are able to manage these patients very well. So why are we talking about this disease today? The literature suggests the mortality of this disease in 1980s was almost 60%. So 6 on 10 patients whom you would be seeing would be dying, right? There have been advances which we are going to take you through in this CGR, and with that, the mortality of this disease has come down to as low as 15%. This mortality is affected by multiple factors. So let's look at what are these factors which impact the outcome of acute variceal bleeding. As told initially by sir, it is the liver status which is an important determinant of the outcome. So a bad liver is associated with bad outcomes in patients with acute variceal bleed. In addition, we are always worried about these patients presenting with infections or they may develop infections. And we are always very critical and we look for presence of any infections, and such patients always are started on antibiotics. And we'll be talking about this in detail. The other players which influence the outcomes includes the other organ failures which develop in these patients, and particularly is the kidney. So an acute kidney injury which develops in these patients, as in any other disease, also determines the outcome. Apart from this, when we take these patients for endoscopy, we also look for, does this patient have a massive bleeding? A person who's got a large amount of bleeding, and those who have, when we do an endoscopy, because when we see such patients in emergency, we start them on some medications. But if you see active bleeding on endoscopy, this is again a sign which should alert us that these patients are going to have a poor outcome. In addition, there are comorbidities and complications which develop, which also lead to a poor outcome, such as development of tumors in the liver and portal vein thrombosis, and the severity of portal hypertension. So, when we manage these patients, we look at, as this patient presents in emergency, as we talked about, the management of such patients, as is for any critically ill patients, involves your ABC. You start them on, you assess what is the status of their bleed, you assess their vitals, start them on oxygen. As required, you arrange bloods, as there has been a massive bleeding in these patients. You start some medicines which are called as vasoactive agents. As I said, the bleeding is determined by portal hypertension. So we're trying to reduce portal hypertension in these patients. And here comes the role of these drugs which are called as vasoactive agents. Apart from that, we start antibiotics for these patients for taking care of their infections. And then we plan for endoscopy in these patients. We look for massive bleeding. We control the bleeding. And then sometimes you're not able to control the bleeding. And that's also we're going to discuss today. What happens and how do we treat such patients? So once the bleeding is controlled, we start looking for what is the etiology of cirrhosis in these patients. Because unless you treat the etiology, these patients will come back again and again to you with variceal bleed and other complications. Treatment of etiology is very important in managing any patient with cirrhosis. In addition, we start them on some drugs which help reduce portal hypertension and help prevent further bleeding in these patients and further episodes of decompensation. That means development of more complications in these patients. So, few years back, we looked at our data of all consecutive patients presenting to emergency. And what we found is that of all upper GI bleeds, 60% of them are variceal bleeding. And within that variceal group, 80% of these patients would have esophageal varices, and 10 to 20% of these patients would be bleeding from their gastric varices. So there are two types of varices which we are going to talk about today. One is the esophageal, second is the gastric varices. Our patients are usually in their 40s. Predominantly, it's a male population. Almost like 85% of our patients, what we see with variceal bleed, are males. Alcohol is the predominant etiology of these patients. Our mortality, when we looked at this data in 2018, it was 22%. Still high, but then we're going to take you through what has happened and how do we manage and how can we get down this mortality to much lower levels. The mortality is predicted by a score, which is a MELD score, which is used to assess the severity of liver disease, and has components of liver, that is the bilirubin, and INR, and the kidney. So we talked about the kidney failure. So here comes a role that kidneys are very important because they determine the outcomes. In addition, if you combine them with hepatic encephalopathy, you can come up with a score, and higher the score, the poorer the outcome in these patients. So let me take you with a classical case scenario, which is a 58-year-old patient who's presented to in the emergency with history of hematemesis. Hematemesis is vomiting of blood, and has black tarry stools, which is again a telltale sign of a patient has had hematemesis. She's had some abdominal distension, was on some diuretics, which has been, and we start looking in the history. Could there be other causes like NSAIDs, what we talked about? So we're ruling out NSAIDs in this patient. These are his parameters. Hemoglobin 5.6, platelets are low, 45,000, you're worried. Do I transfuse platelets? His creatinine is 1.4. You got an INR 2.5. Do I transfuse him fresh frozen plasma? Heart rate is 110. It's an emergency, right? The resident has made a diagnosis. It is liver cirrhosis presenting with hematemesis. So with this, the diagnosis of esophageal and gastric varices, which we are going to talk about, is on endoscopy, right? But there are multiple other things which need to be done to manage these patients. To talk about this, I'm going to call two upon our very good experts in the department who have worked exclusively on esophageal and gastric varices. We're going to talk in tandem now. So first, I'd like to invite Samagra to take us through the management of esophageal varices.
So thank you, Shalimar sir. So before we move on with esophageal varices, the first thing to understand here is that what do we mean by portal hypertension? So when we talk about portal hypertension, it is nothing but an English word that means increase in portal pressure. So what is portal pressure? We all know back from our anatomy days that there are two kinds of circulation. There is one systemic circulation where blood is pumped by the heart into the organs and the blood is carried back. And then there is a portal circulation where blood from the viscera is carried to the liver through a vessel known as portal vein. The pressure in this vessel increases whenever there is damage to the liver in the form of cirrhosis or fibrosis, and that essentially refers to portal hypertension. The important thing to note here is that there are always some collateral channels present, which are usually clinically insignificant, but whenever there is portal hypertension, these collateral channels get engorged due to increased venous flow, and that leads to development of gastroesophageal varices. So whenever we do an endoscopy, we see of something like this, where we have multiple dilated venous channels. And the reason why a bunch of gastroenterologists are talking about this is because of this device, the rubber ligation system device that was developed a few decades back, through which these vessels can be banded and they can be sucked in, and that leads to an appearance like this, where the vessel has been banded. So This development has not occurred immediately, but it is a progressive development that has occurred over a few decades, where initially we started with injecting some sclerosing drugs like polydocanol or absolute alcohol into the varices, and that was associated with some complications and insufficient control of bleed. But now we have endoscopic band ligation that sucks in the varices, and there is much better control of bleed with much fewer complications. So when we talk about portal hypertension as such, when we look at it from the perspective of a esophageal varix, the disease course can be divided into the early chronic liver disease, compensated liver disease, and decompensated liver disease. So whenever a varix has bled and the patient has presented to the emergency department, we label him as decompensated cirrhosis. However, there is a very long disease course which often is missed by us, and that includes patients who have either small varices or who have cirrhosis which is diagnosed only on imaging, or they have large varices. So the management of this is quite different, because for patients who have large varices or who have significant portal hypertension, we can advise something known as primary prophylaxis, which essentially means that we want to prevent development of bleed in these patients. On the other hand, for a patient who has come with bleeding esophageal varices, the focus of management is on acute management, where we try to control bleed as well as possible. And in addition, we are also concerned about preventing rebleed and additional decompensations in them. That comes under secondary prophylaxis. Over this entire course, we are also trying to identify the disease etiology, because ultimately that is the most effective treatment that can reverse all the complications of liver disease. Over this disease progression, the portal pressure is also rising, and we believe that the portal pressure of 10 is a critical pressure over which the complications of cirrhosis start developing, and that level is known as clinically significant portal hypertension. So how do we prevent this first variceal bleed or decompensation? The key here is to identify clinically significant portal hypertension early. So a number of tools have been proposed that have been shown to have value for predicting CSPH, and the most relevant of this is the screening upper GI endoscopy. In a screening upper GI endoscopy, if we see any large varices, that means that that patient has CSPH and that patient needs some treatment. Similarly, other markers have also been developed. The most relevant marker that has come up over the past 2 decades is FibroScan, where we can assess the stiffness of the liver using a transient elastography based device, and that helps us assess how stiff the liver is. And that has been correlated with a risk of development of future decompensations. Some blood markers have also been proposed. For example, something as simple as platelet count can be very relevant, and a low platelet count is a very early marker of development of significant portal hypertension. In research setting, the portal pressure can be directly or indirectly measured using something known as HVPG, or hepatic venous pressure gradient. Whenever we have identified CSPH, we essentially have 2 tools before the bleeding has developed to prevent bleeding. The first is carvedilol, which has come up in a big way over the past 2-3 decades, and this has shown to reduce the risk of bleeding by as much as 50 to 60%. In addition to that, endoscopic band ligation can also be performed prophylactically. So a word about FibroScan, because this is something that we keep on hearing every now and again. There is a group of researchers in the field of portal hypertension which go by Baveno, which developed in Baveno and developed a Baveno consensus. And that group has proposed this set of points of LSM, which can be used as cut points to identify and prognosticate which patients are most likely to develop complications of liver disease. So for example, if a patient has LSM of more than 20, and if that patient or that patient has platelet count less than 150, the Baveno recommendations would suggest that this patient should undergo a screening endoscopy to identify high-risk varices. Similarly, if a patient has a LSM less than 15, and if the platelets are more than 150, we can safely exclude CSPH in this group. This zone remains a gray area, and we need additional tests to identify patients who need further treatment. So we have also worked up in this field, and we have shown in a large cohort of patients that Baveno 6 criteria has a very low miss rate for varices needing treatment, and when applied judiciously, it can very easily rule out patients who do not need a screening endoscopy. Similarly, we also showed that if fibroscan is not available, platelet count and albumin could be a good proxies for that risk, and they are relatively good risk stratification tools. Similarly, we have also used machine learning to identify the relative value of this, and we have shown that endoscopic classification and LSM are the most relevant tools that help risk stratify these patients. Coming to the management of acute variceal bleed. The most important part of management of variceal bleed remains pre-endoscopic, where we assess and evaluate the patient. We confirm that the patient has actually had a GI bleed, the patient has hematemesis or melena, and the patient is hemodynamically stabilized. For that, we need to establish a wide bore IV access. We need to transfuse IV fluids and blood products. We need to give a shot of IV antibiotics, and we need to start vasoactive medications like somatostatin or terlipressin. Somatostatin or terlipressin both work by causing splanchnic vasoconstriction. So what that does is it reduces the portal blood flow, and that causes an immediate reduction in the portal pressure and reduces the risk of bleeding. With adequate pre-endoscopic therapy, more than 60 to 70% of bleeders can be managed without doing endoscopy in the first go, and or their endoscopy can be delayed. So once this has been done, endoscopic therapy is initiated, and this usually includes endoscopic band ligation, as I suggested. And in some patients where band ligation cannot be done due to any reason, such as if there is a lot of blood in the field, glue injection can also be done. In patients in whom endoscopic therapy fails, we move on to something known as TIPS. I'll be talking more about this later. Finally, once the endoscopic therapy is done, the major aim is to prevent rebleeding and prevent further decompensation. In that group of patients, we usually discontinue the vasoactive drugs and start them on beta blockers like carvedilol. In addition, there is an emerging role for statins in this group of patients. So coming to a very important topic, which is regarding blood product transfusion in acute variceal bleed. We had a patient who had hemoglobin of 5.6. What should be the target of HB in this patient? So in this landmark trial published in NEJM in 2013, it was shown that a restrictive strategy where we are targeting a HB of 7 is probably better, since it improves survival and it reduces portal pressure in this group of patients. We have also shown that FFP and RDP transfusions are probably not needed, and they do not have any impact on the prognosis of patients who have thrombocytopenia or who have a deranged INR. Even if we are very strongly suspecting a coagulopathy, we can use tools like thromboelastography, and we have shown that using thromboelastography judiciously can reduce transfusion requirement by more than 80% in patients who have had a variceal bleed, and it can prevent unnecessary transfusions in this group. Once we are done with the basic transfusion and we have initiated some pharmacotherapy in the form of either somatostatin or terlipressin, we then consider the timing of endoscopy. So over the past decade, there has been emerging consensus that immediate endoscopy is not required, mainly because rushing in for an endoscopy probably causes more harm than good. And these patients are not hemodynamically stable, they do not tolerate endoscopic therapy very well, and they have a very high risk of bacterial infections following an endoscopy. So a very important aim is to stabilize the patient first as much as possible with tools like blood transfusions, IV fluids, and give them an adequate dose of pharmacotherapy. This pharmacotherapy is usually advised to be continued for 3 to 5 days as per the guidelines. However, we have shown that in patients who are otherwise stable, who do not have liver failure other than the variceal bleed, the duration of vasoactive therapy can be safely reduced to even 1 day after endotherapy. And these patients do not have an increased risk of either bleeding or worsening survival after discontinuing their vasoactive drug early. Similarly, we have shown that addition of simvastatin to a patient who has had a variceal bleed has an impact on survival, and long-term addition of simvastatin improves survival of up to 50% in patients who have had a cirrhosis and acute variceal bleed. In patients who do not improve despite the best of our endoscopic therapy, we move on to bridge therapies, which include a sense-taken Blakemore tube. We still see some patients who need it, and in this tube there is a gastric balloon as well as an esophageal balloon, and this tube can be inflated and can be kept in situ for 48 hours, and a lot of variceal bleeders can be controlled in this manner. Similarly, there has been new development of a Danis LR stent, which can be kept in situ for those patients who have failed endotherapy, and this can again have impact on controlling bleed without worsening survival. In patients who fail both of these therapies, the most important step to perform is TIPS. TIPS is essentially a shunt that is made between a hepatic vein and a branch of the portal vein, and it rapidly decompresses the portal venous system. While it had initially been proposed for rescue indications only, it has now evident that it also helps reduce rebleed in some group of patients, and a certain high group of patients can be identified, especially patients who are child C or child B with active bleed, or who have a very high HVPG. And in these patients, if TIPS is performed within 5 days of admission, the risk of rebleed can be significantly reduced. So to summarize what I have said till now, the most important step, do not forget the ABC. Make sure that the patient is stable before you send the patient for endoscopy. You confirm that the patient has had upper GI bleed. You take a history to rule out additional sources of bleed like NSAID history of corrosive intake. You always secure a wide bore IV cannula. You start IV fluids, IV antibiotics, and give them vasoactive therapy. And this will take care of a large proportion of bleed and will decrease the severity of bleed at the time of endoscopy. Once endoscopic therapy is initiated, band ligation can be performed and bridge therapy or rescue therapies can be planned. Following endoscopic therapy, a vasoactive drug discontinuation and initiation of carvedilol can be started. Our contributions in this field include the role of elastography in predicting portal hypertension, esophageal varices. We have also contributed in reducing unnecessary blood products and vasoactive drug infusion in these patients. And in addition, we have also worked on the role of simvastatin for improving survival after endoscopic therapy. I will now call upon Shagnik to discuss another important topic, which is gastric varices.
Thank you, sir. So gastric varices are the counterparts of esophageal varices found in the stomach. However, that is where the similarity between both of them end. Gastric varices behave actually differently from esophageal varices in that they are found much less frequently in just 20% cases. They bleed less frequently but more heavily. The blood loss with each episode is significantly higher than esophageal variceal bleed, and the mortality associated with each bleed is higher. And since they are so uncommonly found in cirrhosis, the natural history and course is not very well defined, and our aim of management still remains to effectively control the bleeding episode and at the same time prevent rebleeding. So just quickly reviewing how gastric varices are formed, we've already discussed in detail about portal hypertension. We are aware that the blood normally flows through the portal vein and accesses the systemic circulation through the hepatic veins. However, in patients who have liver cirrhosis, the blood flow through the liver gets slowed down, which raises the pressure in the portal vein, causing hypertension. And this hypertension causes the opening up of several channels which indirectly connect the portal with the systemic vein, called portosystemic collaterals. And it is these collaterals which are responsible for the formation of gastric varices. So if we see, this is just a magnified view of what we are seeing over there. This is actually the body of the varix. And these are the channels or the collaterals. This is the portal vein, and you can see that the blood is flowing into the varix from these collaterals. Once the varix is formed, this blood then flows out either directly into the inferior vena cava through a gastrocaval shunt, or joins the vena cava through the renal vein over through this channel, which is called a gastrorenal shunt. And most of the treatment is based both on endoscopic as well as radiological management, which involves these entities. So this is how we visualize gastric varices on CT. If you see here, this is the main body of the varix. This collateral which is coming out from the splenic vein, this is the posterior gastric vein which is seen over here. And this is the gastrorenal shunt. And the presence of this shunt is often very important in the management. We will discuss this subsequently. So how do we classify these varices endoscopically? When we put in an endoscope, we typically find 4 kinds of gastric varices. The most common is the GOV1. This is basically an esophageal varix which is extending along the lesser curvature. GOV2 is when the esophageal extension goes into the greater curvature. When there are no involvement of the esophagus, we simply find isolated gastric varices, which are just localized to the stomach. As you can see, despite being less common, GOV2 and IgV1 are actually associated with the highest bleeding rates. And these are the more difficult to control gastric variceal bleeding. But this is just the endoscopic classification. It gives us an idea of the anatomy. When the radiologists deal with gastric varices, they use this classification where you have the inflow pathway, that is the veins which are carrying the blood into the varix, and an outflow pathway, which veins are carrying the blood out. And knowledge of these pathways actually gives us an idea what is the best way to treat these varices to stop the bleed or to prevent the next episode. So the management between GB and EV effectively follows the same principles. The resuscitation we have already discussed. It is very, very important that the patients be adequately resuscitated before they're taken up for endoscopy. In endoscopy, there are certain recent advances, such as the use of endoscopic ultrasound. We will be showing this later. And they have helped us improve our management of varices in the acute setting. And again, one of the most important components is prevention of bleeding. And we have multiple options for that, which includes endoscopy, drugs, and radiological interventions. So effectively, this kind of gives us a composite view as to how we can treat these varices differently. The essential problem remains the same, bleeding from this gastric varix. When we do an endoscopy, we can either see the varix directly and inject glue into it. We can use an endoscopic ultrasound where we identify how the vessels are coming in and out of the varix and treat it. Or we can use our radiological methods where we use shunts like this. This is called a TIPS stent. This will be shown later, which diverts the blood away from the gastric varix, causing it to collapse. And when we cannot do that, sometimes we do a BRTO where the shunt vessel which was going into the varix gets occluded and stops the blood flow, effectively causing it to collapse. So coming to what we do on endoscopy, this is the standard endoscope which we use, whereas this is a newer modality which is available to us, which is called the EUS scope. The difference being that this at the tip is an endoscopic probe which allows us to better visualize the varices. So what we see on a standard endoscopic view is this. We can tell about the size, we can tell how it looks, and we can grossly understand where is the location of the varix. But when we use the echo endoscope, we understand how the varix is made up and how the blood is flowing into it. So if we want, we can do more advanced therapies and target the vessels, and we will be showing how it is done in the next segment. So this is what a standard endoscopic glue injection is done. This is the needle, and what we'll do is first position ourselves correctly. With the help of the needle, we first touch the gastric varix and find out which are the soft parts. The soft parts are where blood is flowing and the wall is thin, so it's likely going to bleed from there. And once we identify the soft part, we inject a material which is either N-butyl cyanoacrylate glue. This is what we are using at our center. However, some centers have shown that thrombin can also be used to effectively block this way. As you see in this procedure, we are now going to inject the glue. And once this injection is done, we will remove the sclerotherapy needle and see whether it is bleeding or we have been able to successfully take care of the varix. What EUS does is, the EUS has a Doppler function. So as you can see, it helps us clearly delineate whether the blood flow is there. So once we have done an EUS guided therapy, we can actually cross-check again whether the blood flow has completely stopped or further therapy is required. And that is in essence how it is better. This is what an EUS coil looks like. It comes in a pack like this. This is what it looks like when it's stretched out. And when we inject it into the varix, it assumes this kind of a round shape and takes up the space inside the varix. So now, having successfully done the endoscopy, we are trying to prevent a repeat. And there are three major options available to us. One is we can continue to scope the patient and do glue injection, whatever soft component. And the second is the radiological interventions I've discussed with you. However, the most important thing to note here, which is different from esophageal varix, is that we are not talking about drugs. We are not talking about drugs to lower portal pressure, which is a mainstay of management of esophageal varices. And that is because gastric varix bleeding is not related to portal pressures. The varices form because of portal hypertension, but they don't. But simply lowering the pressure is not going to help me reduce the variceal bleeding. And this was a study from our center, which we have done. This is known in the natural history, and we have been able to validate that in our cohort as well, where we showed that simply lowering pressures to a predefined set target is not going to help in preventing bleeding. To that effect, we are also doing hepatic vein pressure gradient. This was alluded to in the EV presentation, where we put in a catheter through the neck veins, access the various hepatic veins, and put in a contrast. Through this, we are able to visualize very nicely the branches of the hepatic vein. Once it is in place, we can indirectly measure portal vein pressure from here as well. So this gives us an idea as to what is the pressure and how effective our therapies are as well. So how do we prevent a bleed? We had discussed that there are three options. We can continue doing endoscopy, we can use our radiological interventions, we can use both. So this study which we had performed in our center mainly compared endoscopy alone versus combination therapy, which is endoscopy plus either a BRT or TIPS. And the primary result of this study was that using a combination therapy, you can see here, this is the combination and this is just endoscopy. The combination therapy was much better in preventing deep bleeds, whereas the patients who were treated with endoscopy alone continued to have bleeding intermittently. And this is because when we are using a combination therapy, since we visualize the venous inflow and outflow better, we are able to ensure that we have completely taken care of the varix. Whereas in endoscopy, we are mainly dependent on probing and our own subjective system. However, despite having an improvement in rebleeding, this did not improve survival overall. Which just goes to show that although rebleeding is very important, we should not forget about the management of other aspects of liver disease, infections, general health of the patient, vaccinations, and these should occur in tandem to improve the overall survival. Similarly, just doing BRT and TIPS is not a stopgap measure to prevent bleeding. We have to be aware that these procedures come with their own complications. So if we see this is a composite graph of patients who had glue injection, we can see that majority had a rebleed on follow-up, which I've already shown you. Once we did TIPS, the rebleed component decreased. But if you see the other decompensation, which is shown here in violet, the number of decompensations increased. Because TIPS led to hepatic encephalopathy in 30% patients. And this hepatic encephalopathy comes with its own problems. It can cause the patient to fall, have fractures, it can affect the cognitive function of the patient, and this is very important. Similarly, compared to glue injection, BRTO decreased the number of bleeds as well. But you can see that the decompensations were again increased. And the most common decompensation with BRTO is ascites, which is development of abdominal fluid. This can again affect the patient's oral intake, it can affect the patient's mobilization and the quality of life. Therefore, just doing an intervention to prevent rebleeding is not, it's not like a 1D algorithm. We have to take the entire patient into perspective and make the best choice which is available for the patient. So in brief, coming to how we have contributed to the field of gastric varices, we have validated the natural history showing that there is no association of portal pressures. We have shown the further decompensations after radiological interventions. We have done a major clinical trial on secondary prophylaxis of gastric varix, which has shown that combination therapy, that is combining endoscopy and radiological interventions, are better than just doing endoscopy alone. And we have also outlined the long-term outcomes of the natural history of GB because the initial studies were quite old, they are quite dated. And we have newer interventions, so we wanted to see how these newer interventions have impacted the outcome in the present era. Having said that, I would now like to invite Dr. Soumya, who will take us through the endoscopic ultrasound-guided interventions for variceal.
Thank you, Sagnik. So, endoscopic ultrasound is a ultrasound probe that's mounted at the tip of a endoscope, so that the beauty of the probe is that you can easily access the lesion and you can place your probe and do your intervention under direct vision. So this is a 40-year-old alcoholic cirrhosis who presented with upper GI bleed. As you can see, there are minimal or low risk esophageal varices. There is so when you go inside, there is blood inside the stomach, and subsequently, when we see there are large fundal varices, which can be visualized here. So, so the beauty of so when you go see the CT photogram, so these are the fundal varices which are there, and it has a supply from the splenic vein. So if you see the endoscopic ultrasound, you can see just below the probe, which is seen as color in the Doppler, that's the fundal varix, which is around 4 to 5 centimeter size. And we are so with endoscopic ultrasound probe, we try to identify the feeder vessels. That's the supply from the splenic vein. We can retrace that there is a large collateral which is running over here, and that is supplying the feeder, that is supplying the varice. So subsequently, what we try to do in this procedure is we injected with a 19G US FNA needle. We try to inject coil to the feeder vessel to obliterate the supply to the varix. And after injecting, we saw the flow rate in the varice. So the area where the supply is there, that has reduced, but there is some area of the varice that is still showing the flow. Then subsequently we injected another coil to the residual area. But in this patient, so there is a 4 to 5 centimeter fundal varice. So we expected that it is being supplied by another collaterals from the left gastric vein, which is there in the CT scan. So, subsequently, we also try to identify that vessel from the on the endoscopic ultrasound guidance. So this is the left gastric vein, and it is in continuity with the fundal varix, and part of it is thrombus, and part of it is still being supplied by the left gastric vein collaterals, and we subsequently embolized it with a coil and coil injections. So the beauty of the endoscopic ultrasound is that you can easily identify the size of the varix and subsequently occlude both the inflow tract. So that over last decade there has been the literature is evolving in this field. There are few smaller trials, and we are also on one of the trials is ongoing at our centers, and the rebreed rate over 1 to 2 years is around 5 to 15%. So with this, I would like to invite Dr. Sanchita to discuss about radiological intervention in variceal hemorrhage.
Thank you, sir. We have now discussed the endoscopic management and the advances in endoscopy that are used for variceal hemorrhage management. Now we come on to the radiological management of variceal hemorrhage. Usually, radiological interventions have been used as a salvage therapy in cases where endoscopic therapy fails. However, there is new emerging role of radiological interventions in cases where we can prophylactically reduce the risk of rebleeding in patients in whom endoscopic interventions have stopped gastric variceal bleeding. The main aim of interventions in variceal hemorrhages is to reduce the portal pressure. In cases where there is difficulty in bringing down the portal pressure, we can directly go ahead and sclerose or embolize these varices using radiological techniques. The most commonly and the most frequently done procedure is the transvenous intrahepatic portosystemic shunt creation, where we create a shunt between the hepatic vein and the portal vein. By creating a shunt between the two, we can decrease the portal pressure to significant amount, thereby reducing the risk of bleeding. This is an example of a TIPS procedure. We access the right hepatic vein from the neck, and then the portal vein is punctured. This is followed by a post-puncture photogram where we see that we have opacified the portal vein. The entire tract is ballooned, and followed by this, the sheath is inserted into the main portal vein. Here we can see a collateral supplying the path is then stented with. Just 1 second. If there is no hepatic vein present, then the shunt between the portal vein and the shunt is created between the portal vein and the IVC. This is called a DIPS, or a direct intrahepatic portosystemic shunt creation. In a few interventions, what we can do is we can directly embolize these varices without altering the portal blood pressure. These are known as balloon occluded antegrade or retrograde transvenous obliteration methods. Beto and BRTO. In the antegrade approach, what we do is we antegradely access the gastric varices using the portal vein as an access site. In retrograde obliteration, we access the gastric varix using systemic supply, that is from the IVC or the left renal vein. So in Beto or balloon occluded antegrade transvenous obliteration, this can be done using a transhepatic approach, which is an uncommonly used approach, where we can percutaneously access the portal vein, and this is called a PTO, or a percutaneous transhepatic obliteration. Or we can also do this procedure via trans-TIPS approach if a TIPS stent is already in C2. This is an example of a Beto, which was done in a patient who already has a TIPS stent in C2. Here we can see that the patient already has a TIPS stent. We have cannulated the TIPS stent using a sheath from the neck vein. Here we can see that there are large collaterals rising from the left gastric vein. The left gastric vein was then occluded with a balloon, and sclerosant was injected into the varices. This is the final run after sclerosing the gastric varix, where we can see that the left gastric vein as well as the gastric varices have been completely obliterated after the procedure. This is an example of antegrade transvenous obliteration of varices. Pre-procedure planning in these cases is very important. In this case, there was a very large gastrorenal shunt that was giving supply to this very big gastric varix. And so we decided to use an antegrade approach for this patient. The right hepatic vein was hooked, and following this, the portal vein was punctured. Here we can see large gastric varices being supplied from the left gastric vein and the splenic vein. A proximal run from the splenic vein showed these very large collaterals. We went deep inside the splenic vein and then we injected sclerosant into the splenic vein. This is the post-procedure run where we can see that large quantity of glue within the embolized splenic varices. A small component of the varices was left, and here we can see that this was the final run where we can see that there was there was obliteration of the entire varices after the Beto procedure. The Beto can also be done using a transhepatic approach, where we can puncture the portal vein using a percutaneous approach. So we have directly punctured the portal vein percutaneously through the hepatic parenchyma, and similar to the other technique, we have catheterized the main portal vein and then we have gone deep inside the left gastric vein. In this case, instead of using glue as an embolizing agent, we have used multiple coils to obliterate the varices. Another technique for specific for gastric varices is the BRTO technique, or the retrograde transvenous obliteration of varices. The concept of BRTO is very similar to Beto. However, in this case, we are using the efferent supply of the gastric varices, that is the gastrorenal shunt, to sclerose these gastric varices instead of using the afferent supply from the left gastric or the short gastric veins. The gastrorenal shunt is selectively cannulated from the IVC and the left renal vein using a transfemoral route. The gastrorenal shunt is then ballooned using a balloon catheter, and then sclerosant is injected into the gastric varix through it. This is an example of a BRTO technique being done. As in Beto, pre-procedure planning is very important. We have to identify the gastrorenal shunt, and this shunt is leading to this large gastric varix. This is the gastric varix seen in the gastric fundus. The gastrorenal shunt is accessed through a transfemoral route, and then a balloon catheter is placed inside the gastrorenal shunt. Sclerosant is injected into the gastric varices, and then this is supposed to dwell inside the gastric varices for a period of 45 minutes, where we keep our balloon in situ. After 45 minutes, the sclerosant is aspirated and the balloon is collapsed. And then here we can see that the entirety of the gastric varices have been obliterated using this retrograde approach. A variant of the BRTO technique is the plug-assisted retrograde transvenous obliteration, or the PARTO. The only difference between BRTO and PARTO is the use of this plug instead of the balloon that we had used for the BRTO technique. The main advantage of this plug is that it helps to reduce the procedure time. Unlike the balloon catheter, which needs to be removed after 45 minutes, the plug does not have to be removed and the patient can be directly shifted out after this, thereby reducing the time of the procedure and increasing patient comfort. Sometimes we may not be able to access the gastric varices using any of the approaches that we have discussed previously. In these rare situations, we may access them using a transsplenic approach. So in this case, that is what we've done. We've accessed the gastrorenal shunt using a transsplenic approach. We have punctured it through the splenic parenchyma, and after puncturing the the shunt through the splenic parenchyma, we have catheterized it. In a similar fashion, we have used a balloon to occlude the gastrorenal shunt and injected sclerosant into the gastric varices. This is the final image where we can see that the gastric varices have been completely obliterated after completion of the procedure.
So you've seen how endoscopically we can manage, how our radiologists help in managing. So no treatment is complete without taking an opinion from the surgeon. So may I invite Professor Joypal to give his perspective on the role of surgery in managing varices.
So you might be wondering why the surgeon is missing in this action. And especially when the Department of GI Surgery is known for its pioneering work on portal hypertension and the surgery for portal hypertension, where over the last 40 years, it was the legacy of Professor Sabiran Nandi that we followed on and developed the surgery, which is the linorenal shunt, which is actually the surgery which is synonymous with the Department of GI Surgery. But there are two things why surgery is becoming obsolete in the setting of cirrhotics with acute variceal bleeding. The one is that the shunt surgery, which used to be very fashionable in the 60s and 70s, was known to cause a long-term deterioration in the liver function and poor long-term outcomes, even though the bleeding control rates were quite good. And the second thing is, with the advent of liver transplant, with the surgical role has had a paradigm shift. So in cirrhotics, wherever bleeding is to be controlled, it is usually with the advanced endoscopic as well as radiological techniques and tips, which can actually achieve the control in most of the patients. And very rarely a surgeon is called to intervene. And if we are called now, it will be very rare. And when we do so, we usually do not do a shunt surgery. We usually do a surgery which is called splenectomy and devascularization, which is actually staying away from the hilar area of the liver and opening the stomach to tackle the varices directly and doing a devascularization so that the varices are controlled subsequently. Having said that, there is a definite group of patients, say around between 6 to 10% of patients of acute variceal bleeding, which occur not in cirrhotics but in non-cirrhotic cases of portal hypertension. The two primary diseases which we see commonly in our country are extrahepatic portal vein obstruction and non-cirrhotic portal fibrosis. And that is a situation where surgery is still helpful. So traditionally, when we talk about surgical roles in patients with portal hypertension, we talk about primary prophylaxis, we talk about acute variceal bleeding, we talk about secondary prophylaxis. Surgery has an established role as a secondary prophylaxis in patients who have EHO or non-cirrhotic portal fibrosis, where we routinely do linorenal shunts. And if the anatomy is not conducive for a shunt surgery, we end up doing a devascularization. But in acute variceal bleeding, again, the treatment of choice initially is endoscopy. If the endoscopy fails, then you have to consider surgery because TIPS doesn't work in a setting of extrahepatic portal venous obstruction because of the portal vein blockade. And in these cases, and also in some rare cases where there are ectopic varices which are causing the bleed, we need to do a MINC shunt. So over the last decade or so, we hardly do 1 or 2 MINC shunts per year. But before that, when the linorenal shunts were done around 60 to 70 per year, and we used to have at least 10% of these being done in the emergency. So that part has decreased significantly now because of the advances that you have been taken through in this CGM. The beauty of a shunt procedure in these cases is that not only do you tackle the bleeding, but you take care of the hypersplenism, which very commonly is associated with this portal hypertension. You also take care of the problem of portal biliopathy, where the varices are compressing on the biliary tree and causing surgical obstructive jaundice. You also take care of growth retardation in the children who present with portal hypertension, and of course the bleeding from ectopic sites. So surgery has always remained a one-time treatment, addressing all the concerns of a poor patient coming from far-off rural areas with difficult access to tertiary health care. So it's a one-time treatment advocated nowadays mainly for non-cirrhotic portal hypertension in the setting of secondary prophylaxis.
Thank you, sir. So, what we have shown so far, we've made a large database. We've looked at endoscopic procedures, moved from sclerotherapy now to EVL, doing endoscopic ultrasound. In the management of acute EV bleeding, we've shown data on blood product transfusion that has changed the approach, duration of vasoactive agents. We also try to reduce the mortality, and our mortality would somewhere be around, say, 15 to 18%, depending upon the severity of the liver disease. On the long-term outcomes, we've also shown data on iron therapy, statins, and used AI models to predicting outcomes. On the GV front, we again have shown within randomized controlled trial that radiological interventions plus endoscopic management is better than endoscopic management. We've shown the natural history of gastric varices in a large cohort. We've shown further decompensation, and we're working on the models for predicting outcomes. A couple of ongoing studies on EV and GV are going on in the department. We're trying to now even shorten the duration of vasoactive agents further. We're trying to look at doing for a few more RCTs on that front. We're now building up on AI modeling used for using drug monitoring and outcome. On the gastric varices front, we're doing a randomized controlled trial on endoscopic ultrasound interventions versus radiological interventions in combination. We're doing individual patient meta-analysis for both EV and GVs, and we hope that we'll have precision medicine for management of these patients over time. Nonetheless, I'd like to thank all the departments who are involved in the management of patients with us, primarily the departments of radiology, GI surgery, medicine department, and most importantly, the emergency department, which takes the major brunt of these patients and help us in managing these patients. Blood bank. So I remember when I was a resident, we used to get notices from blood bank that we were the largest guzzlers of blood at that time. Now we don't even fall in the top 10 departments because of change in the practice of giving transfusion to these patients. And the nephrology department, hospital administration specifically helps us organize these accessories for these patients, which is really most of our poor patients cannot afford. And all departments, whom I have not mentioned, but then we are very thankful to them. All patients and their family members, we are really thankful to them. We've been very grateful that we've got very good publications over the past 5 years. We've got almost like 30 plus publications with good impact factor journals showing that our results are also changing the guidelines which are for managing both EV and GV bleeds. And in the end, I'd like to thank my whole department, Professor Garg, Professor Vineet Ahuja, who is unfortunately not here right now, Professor Makharia, my colleague Saurabh, who's not right here with us and has moved to AIIMS Gorakhpur, Soumya, and then Samagra, Sagnik, all fellows and residents who are involved in the management, the nursing staff who's there in the management, my mentors who've been there, and nonetheless is to thank Professor Acharya for all his guidance, for which I am here because of him. Thank you. With this, I'd like to open it for discussion. Any questions? So statins, the data right now is more on esophageal varices in terms of improving their outcomes in long run. We've not looked at specifically into the gastric varices per se. So it's predominantly the esophageal varices. For statins, so I'd like to invite Samagra. Why don't you take up this question?
Yes. So statins are essentially have multiple they are working on the heart. They are doing the heart function. They are reducing the requirement of issues that take up the and that way reducing the improving the survival without impacting the outcomes. So in effect, a lot of patients do not have a reduction in AD, but they have improvement in other decompensations. They have a reduction in cycles, encephalopathy, and other complications. But it is an evolving field, and we really haven't explored all the effects.
Sir, please.
Professor Acharya, we did some events and we published in the. Is there any possibility to Is there any other?
But there have been a lot of improvements in the management of mental illness. Now, even the got good drugs, it's a very improving. Yes, there are a lot of improvements. I think we invite you to be here again. We think about doing some more collaborative. No, no, so it's much less. It's about better.
Sometimes we have problem in dealing with scheduling with hypersteronism. So what is the time to deal with hypersteronism? Because given remarks is difficult in patient with pancytopenia.
I think that's a very important question. So that depends how severe are the symptoms of hypertension. So you're talking about the patient maybe symptomatic with anemia. We have these are very rare. Then after the symptoms we talk about in patients who got non-starting causes of hypertension and surgery. We have done selecting certain situations when patients have hepatitis C, which if you are selecting that leads to improvement of then you can treat such patients. So we need to individualize the therapies really what happens.
I know this is the last time.
So we've not been using because our was not very favorable. Now, yes, there is one randomized controlled trial which shows that dynamic maybe associated with improvement in cardiac increase. This is data that we don't have. We are not using dynamic usually as a routine evaluation. Okay. So I think to answer that question, I like Dr. Shyam to your comment. How do you choose between BRQ versus Fixin?
BRO is specifically for a gastric varices. So we don't want to have a fixed associated complications because the gastric varices, even if you work, if the gastric varices do not decrease in size. So it has a different mechanism. So only for gastric specific varices, we select a BRO. This is for esophageal varices. If you are not able to deal the gastric varices BRO, then we do X plus integrate variceal.
So we have our depends on which person we are asking for recipes is not correct not correct. In certain situations, if you think that patient is actively bleeding, we need to use viscoelastic in form of either thermoelastic or but do not use actively and platelets. Be judicious in transfusing practices to these. We don't want high blood hemoglobin release. High hemoglobin release, what pressures these patients need. So, hemoglobin of 7 is good enough. So, other patient of water, yes, you can have situation you can use. Again, use this to for breathing, and you can use it see what kind of condition we need. What issue was for period. So yeah, I think that's a very important question. We don't aim at maintaining a normal production. The more pressure we try to maintain, more risk of having more bleeding in the 90 is solid, 100 is solid. Yeah, please. So I think that's a very important question. That's
emergency department, the leader comes, you are created after getting up. You are another four. Possibly patients who are low routine is not. So if it is a patient who are fancy bleeding, but are low platelet, do not transfuse platelets. We just stabilize them. We give what percentage of you is activations. 95% of them. You don't need to transfuse unless you are enough to only that you will transfuse platelets. Otherwise, we will not need transfuse blood products, and platelets to such patient. It's like parameters. Please remember for residents, it was not an anticoagulated state. You may think a patient IRP is anticoagulated. These patients who also develop deep in trauma. When you use it, so these parameters are just in vitro. In vitro tests, which shows a very different the coagulation cascade of it. In vivo, it's very different. Coming to play and take care of the coagulation. You don't need to transfer based on the absolute number. Yes. No, that's based on various homograms and made by you can show what is the effect of these values and what is the risk of that's what we do. I think that's a very important question. So you learn and also we try putting some more time, start seeing where the answers are, try to put them back. You are able to put in bands. And what we showed is you can inject glue. You can't see, you can't hold that if you can inject glue. Glue is like something like a film, which goes in coagulates the blood and forms something like a film. You can stop it. Now, if you do that, we show you options in terms of use of there are like we can use the therapy tube, we can also use clips. These are the single. Do we have any other questions? Yeah, please. You have any last question? The surgical management uses are very rare. Only since then we have been sorry, we cannot do. We have run out with all radiological interventions. We ask the surgeons to have intervention, and then we can do the aspiration as told you by.